Hello, everyone, and welcome to the Rosa Worldwide Webinar Series. My name is Mike Reed. I'm the Chief Scientist at Rosa. We ask you to check the Rosa website for upcoming webinars. We're going to skip October for the ACOP conference, but we'll resume again in November. During today's webinar, we'll be presenting a recorded version just for ease of language, but the presenter will be live to answer questions at the end of the presentation. If you'd like to ask questions, we ask you to submit them using the Q&A button at the bottom of your screen. Our speaker today is Tomohiro Sasaki. He's a scientist with a main interest in pharmacometrics. He obtained his PhD in pharmaceutical sciences from Kyushu University in 2011 and has worked at Nippon Boehringer Ingelheim. He's currently working at Otsuka Pharmaceuticals since 2015, where he's in charge of modeling and simulation work for several projects. He has experience in clinical pharmacology, preclinical and clinical PK/PD analysis, and modeling and simulation in various therapeutic areas. Please join me in welcoming Tomo. And Heather, you can start the recording.
Good morning and good evening. My name is Tomohiro Sasaki from Otsuka Pharmaceutical Co Pharmacology, and thank you for giving us an opportunity to present our research work. Today, I would like to talk about our research work on the QSP modeling of anti-tumor compound OPB-171775, which is a phosphodiesterase A and Schlafen 12 molecular glue to predict the clinical response in patients with gastrointestinal stromal tumor, GIST. This is a collaborative effort with Rosa team, and I would like to appreciate their dedicated work on this modeling effort. I hope everyone joining this webinar learn something from my talk and get some insights for your future research work and drug development. So this slide summarizes what I'm talking today. So I will start with some background of our compound, OPB, and then goes to some background information of the target disease, GIST, and a key drug, imatinib, which is a first-line treatment for GIST, and also explain the purpose of this analysis, and then go to the detail of model development, including the hypothesis of mode of action of our compound and how that mode of action was modeled with the model diagram, and then explain how the model was calibrated with in vitro and in vivo data. And then move on to the clinical simulation part. At the timing we start this modeling work, only very limited data from clinical was available, and clinical response was not yet obtained. And one of the objective is to simulate the clinical response of compounds. So we did some type of clinical simulation to explore which dose would be the optimal for our patient and population. And also, we have the two target, essential target to express the pharmacological effect. So we explore the impact of target expression as a biomarker in the simulation. And so I will start with some background of our compound and diseases. So here is the semantic explanation how our compound acts on tumors. So OPB-171775 is part of a family of drugs called berberines. And berberine combined to the PDE3A and introduced additional protein as making the complex as molecular glue. And in our case, the OPB bind to the PD3A and also introduced Schlafen 12, which is a key protein to express the anti-tumor effect. So Schlafen 12 is basically a very low level at the normal cells with a rapid half-life. But when we administered OPB, the OPB and PD3A complex make the complex with Schlafen 12. So these molecules make complex, and this causes stabilization of Schlafen 12. And this stabilized Schlafen 12 affects liposomal function through its RNase activity against transfer RNA, and then we inhibit global protein synthesis, resulting in cell growth arrest and induction of cell death. And at a stage of we started the modeling, we hypothesized that this anti-tumor effect is coming from basically two pathways. One is apoptosis, and the other is growth arrest, stop the proliferation of tumor cells. So to describe this mode of action, we made the QSP model and explored this mode of action by using the data from in vivo and in vitro. And another background is about the disease. This is a target disease, gastrointestinal stromal tumors, GIST. This is a relatively rare mesenchymal tumors, and incidence rate is about 1 to 1.5 cases per 100,000 people per year. And it most commonly occur in the stomach and small intestine, accounting for about 60% and 30%. Respectively, and the diagnosis is usually done by imaging techniques like CT and MRI, along with some molecular testing for KIT, PDGFRA, platelet-derived growth factor receptor alpha, and those are the key drivers of tumor growth. And it is known that up to 85% of the population having the KIT or PDGFRA activating mutations. And there are some other exceptions like SDH deficient or NF1 associated subtypes. And treatment is basically done by surgery, and this could be curative for the local diseases. And also the TKI treatment, like imatinib as a first-line therapy, will be used. And in case this failed, other TKI drugs listed here will be used as a second line or further. But the clinical challenges, these TKI shows the tumor shows some resistance to this TKI, basically the secondary mutation of target for alternative pathway. And as you can see on the right-hand side, in case we have the mutation of a particular part, it shows a resistance to the TKI. So the clinical challenge would be how to treat these patients with the resistance to the TKI. And importantly, it is known that GIST shows high expression on Schlafen 12 and PD3A, which are target our compound. So this is why OPB may offer a new therapeutic option, especially for patients who have developed resistance to the TKI. And as I explained in the previous slide, imatinib is the standard of care and first-line therapy for treatment of GIST, and the target of imatinib is KIT and PDGFR, PDGFRA, and they are activated by binding ATP, and this leads to the activation of downstream signaling like the RAS, MAPK, PI3K, AKT. And imatinib bind to this ATP binding pocket and inhibit the activation of these targets. But some patients develop the resistance after approximately 8 months of treatment. PDGFR. So the idea is OPB may offer a new therapeutic advantage, especially for patients who have developed resistance to imatinib. And this slide summarized how the OPB is effective in vivo and in vitro experiment. On the left-hand side, this is data from cell line, and open circle represent the cell line lacking the PD3A expression, and cross circle is when we introduce the PD3A, and also the Schlafen 12, we see the clear anti-tumor efficacy for this cell line. And on the right-hand side, this is the same data in the case for the Schlafen 12. So if we lack the Schlafen 12, we do not see any anti-tumor effect, but if we introduce it, we see the clear anti-tumor effect. So we see clear dependence on the target expression on the sensitivity in cell line for OPB. And also, we did some in vivo experiment using the patient-derived xenograft GIST PDX model. And we see the dose response with our compound with a range from 0.01 milligram per kg to 0.1 milligram per kg, which is relatively low doses. And then the response is consistent or comparable with imatinib, which is a first-line therapy. So based on this data, we can say that OPB is quite effective with at nanomolar concentration for the cell line with PD3A positive and Schlafen 12 positive cell lines. And OPB was efficacious as a standard treatment with standard treatment of imatinib. So these are the background, and based on this background, the research question is as follows for this compound development. So first of all, we would like to verify the mode of action of this compound. So we need mechanical support for anti-tumor effect of OPB, and we have to confirm the non-clinical observation by integrating the mechanistic explanation. And second question is, what would be the optimal dose and dosage regimen in clinical trial to maximum efficacy and minimum safety concern? In our first in human trial, we see some safety concern with a daily dosing. So there is a question about how can we go with intermittent dosing like the QW or Q2W administration. So we want to simulate the clinical response with such intermittent dose. The third one is how the biomarker expression, like the target expression, PDA3, PDA3A, and Schlafen affect the clinical efficacy. So to answer these questions, we did QSP modeling and explore the questions. So I will move on to the model development part. So here is a review of the mode of action of our compound. So our compound bind to the PD3A and Schlafen and make the complex of these three molecules, and then inhibit lysosomal function and cause anti-tumor effect. And for the anti-tumor effect, we hypothesized that there are two pathways. One is growth arrest, and so-called cell cycling pathway, and the other is inducing the apoptosis, which we call cell death pathway. And there are some internal data which support this mode of action. So if we look at the microarray data by using cell line, after the treatment with OPB, we see the induction of P21 and the inhibition of cyclin D1, which is a key element for the cell cycling pathway, cell growth. And also we see the reduced MCL1 and upregulated cleaved Caspar-3, which is a marker for the cell death pathway, cell apoptosis. So based on this assumption, we hypothesize that this complex supplies the Schlafen and then reduce liposomal activity and synthesis of anti-apoptotic factor and cell cycling factors. So this is a model diagram which characterizes what we hypothesize. So first of all, there is a part that to describe the interaction of PD3A, OPB, and Schlafen complex formulation. And then after inhibiting these liposomal activities, we hypothesize that there are two pathways. One is a cell death pathway, which induces apoptosis. And then another pathway, the cell cycling pathway, which inhibits cell proliferation. So I will explain more details how this is modeled in the later slide. And here is the slide to describe the complex formulation of OPB, PD3, and Schlafen. So first of all, we have to determine the concentration of each molecule, PD3 and Schlafen, but there is a limited information of the expression level of PD3A in the tumor cells. So we defer the expression level from cardiomyocyte, which expressing the PD3A higher. I think this might be a kind of uncertainty. We are not sure this expression level is consistent within the GIST cells, but this could be uncertainty of this model. And there is internal data to explore the Schlafen level in the tumor cells, and it seems like the Schlafen level is estimated to be 50 times lower than PD3A relatively, based on our internal data. So simply we assume that Schlafen level is 50 times lower than PD3A. Based on these assumptions, PD3 level will be set to the 220 nanomolar, and Schlafen level is 50 times lower than that, 1.4 nanomolar. And then we describe the dynamic interaction for complex formulation for these three molecules. Again, based on the internal data, by adding the OPB, Schlafen 12 is 5 times stabilized based on the expression level. So to reproduce this fourth increase by adding the OPB, we set the K on and K off to reproduce this fourth increase. And also there are publications about the elimination rate of each molecules. For example, Schlafen 12, it was reported very short half-life, like 1 hour. And Berkeley and Schlafen 12 complex is reported to be very relatively short half-life, 8 hours. So we set this half-life from publication as the elimination rate for these molecules. And regarding the downstream effect, first of all, the inhibition of liposomal activity, again, we have internal data here. So our complex reduced the liposomal activity about 50% maximum. So it was set 50% inhibition at maximum here. And also this reduced liposomal activity, the liposomal activity caused the induction of survival factors. And our internal data suggests that by adding the OPB, this survival factors was reduced. So we introduced this quantitative relationship on the how the liposomal activity induced survival factors. And further downstream effect, here is a graphical explanation how each molecule is interact in this cell death pathway. So the survival factor like BCL2, MCL1 will inhibit the BAC or the BAX on the mitochondria, and then the BAC and BAX induce the cytochrome C and cause activation of cleaved caspase and cause apoptosis. That's what we call these BCL2 and MCL1 as survival factors, and the following downstream cascaded cell death factors. And from our internal microarray data, we see the caspase 3 activation after adding the OPB. So again, we introduce this quantitative relationship and to model how the survival factors inhibit the cell death factors. Actually, here we assumed 80% of maximum cell death factors activation by this pathway. And these are explanation on the cell death pathway. And this slide summarizes how the cell cycling pathway was modeled. The Berkeley like OPB or other molecule like anagrenide is reported to inhibit cell proliferation. And there are some data from our internal or the other type of PDE3A inhibitors that alter the expression of key element of cell proliferation, like cyclin D1 and P21. For example, anagrenide, which is another PDE3A inhibitor, increase the cyclic D1 up to 1.7-fold, and P21 reduced to 0.7-fold, and increase the P21 to 1.27-fold. And also our internal data suggests some quantitative relationship between the OPB treatment and expression level of these self-cycling pathways. So, and based on this data, it shows that 60 to 90% inhibition of downstream cycling regulators. So we introduced this value into the model. And finally, we calibrate this model by using data from in vitro cell line experiment. So we check the model simulated anti-tumor effect versus the observed data at 72 hours incubation with a different concentration of OPB. And some parameter is calibrated. And based on after calibrating some parameters, we see the clear consistency between the simulated exposure response, concentration response, and observed tumor growth with different concentration of OPP. So model will reproduce the observation for several lines. And there is a question, which pathway, I mean, the cell death pathway and cell cycling pathway is dominant on the anti-tumor effect of this compound. So we did some exploratory simulation to check it. So on the left-hand side, this the concentration effect on the tumor growth over time, and we see the concentration dependent decrease on the tumor growth when we administered at week 1. And then we turn off completely the cell cycling pathway. That is on the right-hand side. But we do not see clear impact on that, the concentration effect on the tumor growth. So the cell cycling pathway is considered to be minimum impact on the tumor growth. But if we turn off the cell death pathway, it's dramatically change the concentration relationship. So we conclude that the OPB efficacy is more dependent on the cell death pathway than the cell cycling pathway. But even if we turn off the cell death pathway, we see small concentration dependency. So there is a minor contribution of cell death cycling pathway. And more importantly, this depends on the type of the basal cell line with different parameter sets. So maybe we can, there are some uncertainty of this conclusion, and what type of cell would be the more important to explore which pathway is causing the cell anti-tumor effect. And finally, we calibrated the model with our in vivo experiment, PD expression-derived xenograft model in GIST patient. For calibrating this GIST patient, we see some delay on the onset of effect. For example, the drug is administered on day 0, but from day 0 to day 3, there is no reduction in the tumor volume. And then the tumor goes down around after the maybe 7 days or 10 days. So to describe the delay in the effect, we introduced cancer cell death, and counted as a tumor volume, even if dead. So this
Heather, we're getting some audio issues.
So we need
just
some
check?
calibration for the EC50 and here coefficient to reproduce this dose response. But by after adjusting these parameters, the in vivo response was well reproduced. And this is a kind of background information. So to simulate clinical response of OPB, we need some type of information in how the drug is actually effective in actual clinical population. So to bridge this information, we utilize the data from imatinib. And this is the data from the PDX patient-derived xenograft model. And imatinib and OPB shows very comparable efficacy with a dose 0.03 milligram per kg for OPB and 50 milligram per kg for imatinib. So we utilize this consistency, I mean, in effect, to establish equivalent in vivo doses for OPB and imatinib to simulate the OPB clinical efficacy. And also we are trying to simulate the clinical response after getting the patient, after patient get the resistance to the imatinib. So to do such simulation, we created the model for imatinib as well. This briefly describing how we did for describe the imatinib effect on our platform. So as I explained in the very early slide on this presentation, so imatinib inhibit the KIT and PGFR. So this mode of action is integrated, but not only this pathway, imatinib also known to affect the vascular density and immune response. So these are also models to describe the imatinib mode of action. And as I mentioned, imatinib, the patient gets the resistance after treatment by imatinib. So this resistance mechanism is also integrated that this mode of action is relative. It will be a decrease after the serious treatment of the imatinib as a function of imatinib AUC. So, overall, the model diagram is look like this. Sorry to very busy slide, but if we explain, first of all, we have the three molecule interaction to make the complex, and then cell-death pathway to induce apoptosis and cell cycling pathway for inhibiting the proliferation. And also we have the imatinib model to explain the imatinib resistance and also the to extrapolate OPB clinical efficacy from the equivalent dose in the GISD PDX model. Imatinib PD also integrated, and KIT PDGFR is also affecting the cell cycling and cell death pathway. So based on this model, we did clinical simulation. And to simulate clinical response, we adjusted some parameters to reflect the actual clinical patient. First of all, it's initial tumor size and tumor doubling time, which is different from the PDX model. So we get this information from the publications of how the initial tumor size is and what the doubling time is in the actual clinical population last year. And what we did simulate was the tumor volumes at the stage of a non-clinical, I mean, they're using tumor cell line or PDX model, but actual clinical endpoint is SLD, some of the longest diameters. So we have to calculate SLD from tumor volumes in the model. To do that, we assume the shape of tumor like this, and then create an equation to calculate SLD from tumor volumes as with this equation. And here is the simulated clinical response and observed clinical response in patient with GIST after imatinib. So blue open circle and connected line is the actual observation from GIST patient and change from baseline in SLD. And yellow one is imatinib simulation with 110 milligram BID, which is the clinical dose. And it seems like the model will capture the tumor reduction at patient. And so based on, by using this model, we simulate the OPB clinical efficacy with different dose from QD to Q2W with this range of the dose strengths. And also, as we are trying to simulate the response with the resistance of imatinib, so this virtual patient was initially treated with imatinib for a year, and then we introduced OPB after that. Here is the simulated SLD with different dose for a year with QD 1 week on, 1 week off with drug holidays, and QD 1 week on and 2 week off, and QW. We see clear dose response here, and here is the simulated percent reduction in SLD. Based on the RECIST criteria, 30% reduction is a partial response, and we are targeting this 30% reduction. And based on the simulation, we can achieve this target with even if QW or Q2W, for example, Q2W 2 milligram can achieve this target 30% reduction. So this is just one typical patient simulation, and to simulate the simulation at the populations, we created the virtual population. Here is a summary how that was done. So we initially set the biologically plausible range of the model parameters from the literature. And parameter was sampled randomly, based assuming the log normal or log uniform distribution, and get the 100 possible virtual populations. And then constraint. We defined constraint based on the literature data. For example, GIST doubling time is ranged from 1 to 144 months. And the possible tumor volumes and how the resistance was created to the imatinib. Based on these constraints, we select the plausible virtual populations. And if the patient goes outside these constraint bounds, we removed. And finally, we got approximately 300 plausible virtual populations, virtual patients, and we use this plausible population for the simulation. Here is some kind of result for the calibration. So we simulated the effect of imatinib as a calibration for this population, and calculate the RECIST response rate based on the population data. On the right-hand side, we compare the actual response rate from the publication and the simulated response rate. It seems like the response rate is quite constant for the responders and stable disease and progressive disease. So we conclude that this population will reflect the actual population for the imatinib efficacy. Then we utilize this population for simulating the OPB exposure response, dose response. Again, we started with the daily dosing and then have the intermittent dose like QD, we are 1 week on, 2 week off, QW and Q2Ws. And based on the simulations, more frequent dosing at lower dose that in somewhat faster response to OPB, like the QD or QD 1 week. And the less frequent dose protocol may require longer time to achieve the responder. And finally, we calculate the response rate based on this simulation time course at 8 months of treatment. And again, so higher dose with higher frequent, like QD shows a relatively higher responder rate. But intermittent dose QW or Q2W also shows the relatively promising response rate. And we explored which parameter drive the clinical response by using simulations. So we check the individual parameter distribution and check the correlation in the SLD change and parameters. And here is the summary of what is the key factors to introduce the clinical efficacy. So we applied the chi-square feature selection algorithm in MATLAB and rank the model observable as which is more impact on the clinical response. As a result, as expected, the 3 complex and Schlafen trap and liposomal activity was identified as the top 3 predictive biomarkers, and the 4th one is PDCA. So this target expression as well as the liposomal activity is a very important factor to express the clinical efficacy. So these results suggest that the expression level of the target and the degree of liposomal activity before treatment would be a kind of biomarker for predicting the response. And finally, we characterized how these expression level change the clinical response, and we changed this expression level from 0.1, 1/10 to the 10 times for each expression level, and how the SAD change will be changed as a percentage change. This is so busy said, but the key message is that the simulation provides a quantitative characterization of the impact of target expression on therapeutic efficacy, which could support the definition of inclusion criteria based on the expression levels. Okay, this is a summary of my presentation. So in vitro and PDX evidence suggests that OPB effect on GIST, cancer cell reduction and tumor growth inhibition is similar to imatinib, and imatinib-resistant cells remain responsive to OPB. And QSP modeling suggests that OPB is efficacious in patients with or without imatinib resistance, and predicted efficacy is robust to patient variability. And under the reasonable assumptions, a range of clinical dosing protocol ranging from 0.1 mg QD to 2 mg Q2W are expected to achieve at least partial response, a 30% reduction at 8 months, And also the PD3 and Schlafen expression are key determinant for predicting the OPB response. And there are some uncertainty remains, but we think the OPB is a viable candidate for treatment of patients with GIST that are resistant to imatinib treatment. So this concludes my presentation. Thank you very much for your attention.
Thank you, Dr. Sasaki. We do have a couple of questions from the audience, and so I'll go through some of those. First question, I'm interested in the increased EC50 to explain in vivo dynamics. Could you please comment on the mechanistic understanding on the increase of EC50 compared with the value estimated from in vitro data?
Yes, can you hear me?
Yes.
Right. Yeah, thank you for the question. I think this is very important point. And for now, we do not have clear answer for that. But what we think is that, first of all, the cell line is a cultured cell line, and it's different from the actual patient tumors. In the PDX model, we get the actual patient tumor from the patient. So maybe the environment of the tumor is different from the cell line and patients. This is one. And the second is exposure perspective. A cell line, we measure the concentration, but there are some uncertainty how the drug is bind to the media or protein existing in the experimental conditions. And also we have uncertainty about the protein binding in the tumors that was not measured in the current trial. So there are some uncertainty there in terms of the exposure and protein binding. That's my understanding, but again, we do not have a clear answer for that.
Okay.
Yeah.
Thank you. I have a related question, which this is more translation from mouse to human dosing. You assumed based on looked like you assumed based on the in vitro data and the mouse data that there was an equivalent effect at a certain concentration of OPB compared to imatinib. Do you feel that will also translate when you get to the human in vivo dosing setting?
Yes, that's also some kind of uncertainty. So at the time we started the analysis, that the one we get information from literature is only about imatinib, and there are some overlapping the mode of action with OPB, but not completely overlap. So prediction from the extrapolation from imatinib is kind of uncertainty how reliably estimate our clinical efficacy for OPB. So that will be resolved when we get the data from clinical study.
Okay.
Yeah.
The next question is, did you explore possible uncertainty around the development of resistance to OPB?
Yeah, no, actually not. So we have not yet data about the resistance to the OPB, both from neither from the in vitro or in vivo and in clinical. So at the time we did the analysis, it may be difficult to investigate resistance to OPB. So we did not explore that.
Okay. Then another question relates to outcomes of treatment and assessing value to the patients. What do you think it would take to have a correlation between the diameters of the tumor and extrapolating that to patient survival?
Yeah, that's also a very great question. The survival of the patient is not the scope of the current analysis, but there are some reported equation to predict the tumor, patient survival from the tumor size. So maybe we can utilize such reported equation to predict the patient survival based on the current predicted SLD reduction. But we have not yet explored it.
Okay. The final question is, how would you approach the question of often cancer therapies are added to existing therapies the patient may be on? So not just imatinib, but also chemotherapies or radiation treatments. things like that, where there might be other factors that how would you represent that in the model?
Yeah, that will be next challenge for us. So that we have not yet get the idea what kind of drug will be add on our therapy, or what kind of treatment will be done, like radiation. But if we have such kind of idea, we can integrate this into the model and simulate how that kind of combination will be effective. Actually, yeah, this is one of the great interests from the research side. What would be the best combination partner? So yeah, as a next stage of this analysis, we should explore that kind of approach.
Great, thank you. Well, that completes the question and answer session. I'd like to thank our speaker again for an excellent presentation today. I'd also like to thank the audience for your attention and for your questions. I'll remind you to check the Rosa website for upcoming webinars starting up again in November. And at this point, I'd like to close the webinar today and thank everyone for attending, and have a nice day.
Thank you so much.
Thank you, everyone.
Thank you.